Welcome to Adoctorsjourney Podcast, navigating life and medicine with coaching and healthcare innovation. I'm your host, Miguel Villagra. I'm the founder of Adoctorsjourney, which is a coaching platform that helps physicians get involved with digital health. And in today's episodes, I have the privilege of having an amazing guest, Dr. Robert Pearl. He is a transformative leader in healthcare, an educator, author, and podcaster. And Dr. Pearl served as CEO of the Permanente Medical Group for 18 years, leading 10,000 physicians and overseeing the care of 5 million Kaiser Permanente members across the U.S. In addition to his leadership role, Dr. Pearl is a clinical professor at Stanford University School of Medicine and teaches healthcare strategy and leadership at the Stanford Graduate School of Business. He's a best-selling author of the books Mistreated and Uncaring, and his latest book, which we're going to talk about, ChatGPT MD, will delve into the role of artificial intelligence in healthcare. It's a real pleasure to have him here. Welcome to the podcast, Dr. Pearl.
Thank you so much, Miguel. Thank you so much for inviting me.
Fantastic. So the first thing I want to touch base with you, I'm amazed about your journey as a leader in healthcare, and I want to hear how you can reflect on being the president of the Permanente Medical Group, where you were leading 10,000 physicians and 38,000 staff. What are the key lessons learned from overseeing this nationally recognized company?
The first thing I'll tell listeners is that there's always a lot of serendipity. I'm a physician. I fix children with cleft lip and cleft palate. I've done a lot of work around the globe, volunteer mission work, and I loved my clinical practice. I was never really that interested in taking on administrative roles, but when people asked me to do a job, I would do so. And the nice part about Kaiser Permanente is that, first of all, there's an entire ladder of progress around leadership. So you start with, I'll say, relatively small jobs, although they're big, but you have a lot of help in doing them. You take on more and more accountability. Got a chance to go to the Stanford Graduate School of Business for some executive training. And then when the opportunity came about, Kaiser Permanente was in big trouble. In 1998, we had lost hundreds of millions of dollars. We only had 2 days of cash on hand, and we had to borrow a day of cash to meet the state requirements. And the CEO at the time stepped down. And I wasn't even at that time that interested in taking on that role, but people I asked to do it basically said they wouldn't do it. And as one of my mentors told me, windows open and windows close. And I had no choice, but I'd either have to leave the organization because I didn't want to follow the people who were vying for the job, or I had to throw my hat in the ring, which is what I did. And then built it up so that by the time I left, we were number one of 1,000 programs in quality based upon the National Committee for Quality Assurance. We were able to provide same day and next day access 70 to 80% of the time for routine problems. Obviously, all the emergencies got seen, but routine problems, access, service, quality. These were the areas of pushing. And I found the entire leadership process to be incredibly rewarding. I think of it as a second career after my clinical one. And as you well know, now my third career as a professor, as a writer, as a keynote speaker, as a consultant. And as I view the evolution across that time, I went from, as a surgeon, maybe having 10,000 patients, many of whom were multi-generational. Parents had a cleft lip and the child had a cleft lip, and I had operated on both of them by the time I left Kaiser Permanente. Then as the CEO, as you say, I went from 10,000 to 10 million, or it's 5 million, but actually about 10 million in terms of my total influence. And now I'm trying to do hundreds of millions of Americans and people around the globe being able to improve quality, save lives, make care affordable, and address many of the issues like the burnout that's rampant in the profession today. So I would say it's quite reaffirming, but it's not that different than the other jobs that are out there. It's just serendipity. As the windows open, you have to be in the right place at the right time. My advice to people is jump through them, take the chance. You're more likely to regret what you didn't do than regret the things that you did. Volunteer and step forward and take a risk doing.
That is fantastic. A great advice, and give me the perfect segue for, in this podcast, we talk a lot about healthcare innovation and how we can shape the future of medicine that is due for an upgrade for a long time. You just mentioned burnout and so many inefficiencies that sometimes physician leadership is needed to make those changes. You have this book, ChatGPT MD, and I'm very passionate about artificial intelligence and how it can shape that future of healthcare in the United States. And One of the messages that struck me from your book is that idea of how AI can shift back the power to patients and physicians. And I want to see if you can give me some insights about that, how you convey the message.
As you mentioned in the introduction, I've actually written 3 books. The first book, Mistreated, Why We Think We're Getting Good Healthcare, We're Usually Wrong, described the American healthcare system as a 19th century cottage industry. Fragmented, doctors scattered across the community, unconnected with each other. It was paid on a piecemeal basis. We call it fee for service. The more you do, the more you get paid. Whether there's any good or not doesn't really matter. If you see a patient twice for a single problem, you get paid twice as much as if you solve it in one visit. It uses technology that's left over from the last century. Most of the electronic health records are programmed using outdated type software applications, but actually the most common way that clinicians communicate is through an 1834 invention called the fax machine. When I teach at the Stanford Graduate School of Business, I tell my students about the fax machine. They ask me, what's a fax machine? They've never seen a fax machine, and that's the way that medicine communicates. We think of it as being so cutting edge, but 100 and some odd years into the past. And there's not a leadership structure capable of making significant change. The CEOs of all the different companies are all different pieces. But if you wanted to actually improve the processes, you'd have no one with their role and responsibility able to do it. So I wrote the book and I talked about these 4 pillars and talked about ways to improve it. And hard to say this, but I was a little naive. I thought that people reading it and seeing potential ways to save lives, to improve the health of people, they would immediately change. Nothing happened. So as a professor, I often ask myself, okay, if change doesn't happen when it's so logical and I think pretty well presented, what's going on? I did a lot of research and I came up with the conclusion that had to be the culture of medicine. I wrote the second book on caring. By the way, the promise from all my 3 books go to Doctors Without Borders. My second book was on caring how the culture of medicine kills doctors and patients. And I pointed out the various ways that the teachings left over from the past are not applicable today and contributing greatly to, as you mentioned, the burnout that clinicians experience and to the compromised care that patients have. I thought that there was a reason why healthcare in the United States costs twice as much as almost any other nation. We spend $12,500 per American. Switzerland's, I think, $9,500. Germany's $7,500. Everywhere else is half of us. And yet our outcomes are last compared to the 12 most industrialized peer nations. As you pointed out, we have high rate of burnout, over 50%. We have 400,000 patients who die every year from misdiagnoses, 250,000 from preventable medical errors. We'll talk some more about all the different ways that the healthcare system actually in the United States fails, like expectancy, longevity, 5 to 6 years behind other countries, maternal mortality 3 times higher. We could spend this entire podcast talking about the problems. But again, I published the book and I expected change would happen and nothing occurred. So I once again asked myself, what's going on? And what I came to the conclusion was that we just simply didn't have the tool, the way to make the change happen. It wasn't that people didn't realize the system was broken. It wasn't realized that the culture was problematic, but they didn't have a way to make these changes, to reduce the misdiagnoses, to avoid the medical errors. Yes, we could get better, but it was going to be incremental. And then November 30th of 2022, OpenAI releases ChatGPT. And this is a remarkable advance. It's different than all of the other AI. We should stop talking about AI. We should talk about generative AI versus narrow AI versus rules-based AI. This AI could transform healthcare the same way the printing press centuries in the past changed reading, or the internet changed information distribution, or the iPhone changed communication. We now had a tool that could accomplish it. And that's why I wrote the third book, ChatGPT MD, how AI-empowered patients and doctors can take back control of American medicine. That's what I'm so excited about right now, because this technology can save hundreds of thousands of lives every year. When you look at why do we have such poor performance in American healthcare? Why do we have such high rates of burnout? What's been missed, I believe, is that we have a crisis of chronic disease. Chronic diseases, according to the CDC, account for 30 to 50% of heart attacks, strokes, kidney failure, cancer. These are diabetes, hypertension. And we do a poor job of taking care of these problems. Hypertension accounts for 40% of strokes. We control it 55 to 60% of the time. Diabetes, by the way, that impacts 1 in 3 Americans. It's the leading cause of kidney failure, major contributor to heart disease, accounts for 80% of peripheral amputations. We control that less than 30% of the time. And it's not that we don't have technological tools. Many of your listeners and viewers may be working in these various areas. We have wearable devices. My colleagues at the Stanford Engineering School, these are Band-Aid-sized monitors that can measure blood pressure, pulse, blood oxygen, blood glucose. And I can't find a single physician who is using this with his or her patients. Now, why? We have a technology that's 99.9% accurate, could totally change health, better management of chronic disease, avoidance of these severe complications, life-threatening problems, and we don't use it. And the reason is because we haven't figured out, we don't have a system that allows us to use that data. As an example, you see a clinician diagnoses new hypertension, prescribes the medication, and what does he or she say to you? Come back in 4 months. After 1 month, we should be able to figure out, how are you doing? Change the medication if you're not doing well. And by the way, when you come back to the office 4 months later and your blood pressure is elevated, the clinician is likely to say, white coat syndrome. You're just nervous, you're fearful. Come back in 4 more months. We don't do a good job because we don't manage that data. Generative AI can do that. It can tell the patient every day how they are doing every week, whether they're making progress after a month. It can look at, let's say, 3 blood pressure measurements a day, the 100 blood pressure measurements. No doctor wants to receive an email with 100 blood pressure measurements. The physician wants it clogging up their EHR. But for generative AI, it's a simple task to be able to say, you're making progress, you seem to be having outcomes that align with what your clinician expected, or no, you're not making progress. And then the clinician, not even making you come to the office, a virtual visit, a telephone visit, an email, a secure message can say, let me change your medication and let me know what generative AI says in a month. This is a radical change, a major transformation. Acute visits, you have appendicitis. I see you maybe 4 or 5 times and we're done. You come to my office with diabetes, I'm going to see you 4 times a year for the rest of your life. That's 120 or 150 visits. We just are swapping medicine. Today, clinicians are seeing more and more patients all the time. What we're seeing is that the visits are now down to 17 minutes. You just can't do great work. And when you don't do great work across the day, when you cut corners, that's where misdiagnoses come from. And that's where moral injury and burnout has its origin.
Yeah, I think that there's so much to unpack, but one of the first things that I want to touch base with you is, and you kind of elaborated nicely, I think there is a gap between a lot of this new disruptive technology and the frontline providers. And the question always is not only the why, but the when, right? Why this happened, that frontline providers are the ones that will be using this technology and yet they're not using it. Some of them they're not even know about. And that's one of the reasons why I'm actually doing this podcast, because I'm still a clinician and a frontline provider in hospital medicine. And a lot of my audience are physicians that are busy taking care of patients. So the first will be the why, and how you see that coming, or the when will be the second question that follows.
In the book, ChatGPT MD, I point out that any technology that slows a clinician down or compromises the individual's income is not going to be used. The problem with technology is usually not the technology itself. I get calls all the time from innovators, from entrepreneurs. They have a great technology, and yet it's not being applied, as you say. It's not being embraced. And then I always say, yeah, because it's going to take them an extra hour a day, and they don't have an hour a day. Or that technology may be great, but they can't bill for it. No one wants to pay for it. It can't be monetized. Their income is actually going to go down as a consequence. And so my answer to you is really going to be, it's going to happen not when we advance the technology. It's not like a silicon chip. You got to keep having those lines become closer and closer together. That requires major technological innovation. No, it's going to require a system change. Think about it this way. What I've told you so far is that we could reduce the cost of care. We could raise the quality of care. we could eliminate 30 to 50% of heart attacks, strokes, kidney failure, cancer, etc. If we did all of that, what would happen to clinician income? What would happen to hospital income? They would go down. This is not going to be rapidly embraced till we actually change the system of medicine, and by that, how we reimburse clinicians. And if we can move from a system that simply rewards volume to one that adequately rewards health, adequately rewards patients who don't get heart attacks and strokes and cancer and heart failure. Now we have a win. Patient wins because, of course, they don't get sick. They don't need to have a procedure. I don't know anyone who says, I'm so glad I had a heart attack so I could have my coronary arteries open back up. I think everyone would rather say, I'd rather not have had that heart attack in the first place. It helps the providers of care because now they can spend more time with patients. They can increase the depth of the doctor-patient relationship. Rather than seeing every patient every 4 months, they can see the patients who are not doing well. They can go home at night feeling they did a great job, not cutting corners and experiencing moral injury. And it will positively impact the payers, the people who fund the care, whether it's the government, whether it's the private businesses, whether it's individuals. So this to me is the win. And I think that within 5 years, this technology will be ready to be used in that kind of way. Remember, this technology is improving. It's doubling exponentially every year, becoming twice as powerful each year. In fact, it's actually advancing more rapidly than that. But even at a doubling every year, it means in 5 years, it's going to be 32 times more powerful than today. And by a decade, 1,000 times more powerful. That would be like your car going as fast as an airplane in 5 years and a rocket ship in 10 years. We'd be making major changes in how we think about things, where we put hotels, how we build roads, how we think about businesses, how we think about global travel. People could live on one coast and actually work on the other coast, and the commute time would be no different than driving through LA or New York traffic early in the morning. But we don't think that way. Right now, people are still focusing on the issues of today, and they're not able to pick their heads up and see the opportunities tomorrow. I think they're going to happen, but as I say, until we advance the payment system and then integrating clinicians together, I think the day of the individual physician taking care of the single patient, and it may have worked when the problems were pneumonia or a broken bone or appendicitis or something like that. But today with chronic disease, patients require 3, 4, 5 different specialists, and they need to be coordinated in the work they do to achieve the best outcomes at the most affordable price.
That is amazing. That's fascinating. So now, you did mention about your book on caring. How do you touch base in about the culture of medicine, right? The need or the call to action for a change. And I want to hear your reflections, if you can get more deeper on how do you foresee artificial intelligence and these new technologies, what implications they might have, or what examples you might foresee we will have in the future about how we'll change the culture of medicine?
The first thing is that the primacy of the physician office is going to shift. By that, I mean that if a patient awakens in the morning with a symptom and they don't know what's happening, the only option they have today is either to go to Google, in which case they'll get a whole variety of links, which will tell them a lot of information, but won't be able to help them make a decision, or call the doctor's office. A great example to me of this was a podcast I did a couple of months ago, where the podcast host, at the end of the conversation, we were off air, said, Dr. Pearl, you're a skier, you are a physician. My husband fell about 3 months ago skiing. His arm was over his head. He slid about 100 feet. His shoulder still hurts him, but he can't use it as well as the other side. What do you think's going on? And I said, I think I know exactly what's going on, but I'll tell you what. You said on this podcast you don't use ChatGPT. I want you to go to ChatGPT, download the free app, put all the information in that you can possibly think of, just see what it says. 5 days later, she calls me back. She says, thank you so much. I went to ChatGPT. It said he most likely has a rotator cuff tear. He'll need an MRI, and he should see an orthopedic surgeon because the treatment is most likely to be surgery. Now think about how that compares to Google, where she would have gotten 100 different potential diagnoses of shoulder pain. She would have gotten told to see an orthopedic surgeon. Why? Because it was protecting itself, the application, not because it would tell her that he probably needed surgery. And she said, that's just what we did. The surgeon diagnosed the rotator cuff tear, got the MRI, did the surgery, and said, had we waited a few more months, he probably could not have reattached the tendon to the bone because the muscle, which it has its origin, would have contracted it so far. That's the empowerment of patients. And so when the patient goes to the office, you can think about it as being screened, not in some kind of triage negative way, but in an educational way. They'd go earlier because their problem required more rapid, quicker intervention. They wouldn't go at all if they were doing well. And when they went with a new medical problem, they would have a lot of expertise around it. They would understand it. And the clinician could start often where the old visit ends by going into the details. It wasn't hard for them to understand what was happening with the shoulder, what the rotator cuff was, why it needs to be repaired. So that's one big change I think that's going to happen. You'll have your relationship with the clinician, but it's as though you have a concierge individual, in this case a technology, that's going to be able to be the first place that you go. The second thing is, regardless of which aspect of healthcare, you're a hospitalist, and a lot of your patients are very sick, but you also probably take care of the people in the med-surg ward. What happens in a med-surg ward? A nurse comes around 8 o'clock in the morning, sees the patients, and comes back at noon. What happens between 8 a.m. and noon? No one knows. We have no one. We have these monitors at the bedside. Yes, they ring if there's a emergency, a life-threatening emergency. 97% of the information that's generated, we pay no attention to. And as you well know, there's a certain number of patients who will deteriorate over the next 24 hours, end up in the ICU. And even when you resuscitate them, the chance of dying over the next 3 months is 4 times greater. This is going to fill in the gaps. I often get asked about mental health. Major crisis in the United States, getting far worse. Not enough therapists here. So what happens? We see patients every 2 or 3 weeks. What happens in between? We have no idea. If the patient's getting worse, maybe becoming somewhat suicidal, we don't know. Everyone wants to say, is this technology going to get rid of and displace doctors and clinicians and other mental health workers and nurses? No, it's going to augment. It's going to fill in the gap. It's going to take care of the places that we today don't do well. We're thinking about the misdiagnoses and the errors that lead to death. 400,000 people, as we said, dying, another 400,000 with permanent disability. It's going to provide a check. It's going to be able to provide up-to-date information. I think about a surgeon I know very well. She did a very complex neck procedure. Knew she hadn't done any damage to any of the nerves, and yet at the end of the case, the anesthesiologist said to her, I can't take the tube out because the vocal cords are what we call adducted, stuck together in the middle. And if I take the tube out, it's going to block the airway. Should I send the patient to the ICU? Do you want to do a tracheostomy? What would you like to do? She pulled out her phone. She went to ChatGPT, and she found 4 case studies of exactly the same thing. And in each case, the reason why those cords were stuck together was that the local anesthetic that we use in the neck, we actually don't use it because of the local anesthetic. We use it because of the adrenaline in it to constrict the blood vessels and allow a bloodless field. For whatever reason, in some people, it just spreads more rapidly, and it spread to the area of the larynx, the vocal cord. And in each of these 4 cases, 30 minutes later, the anesthetic wore off, the cord separated, and the patient went home. That's what happened in her case. So these are just a few of the ways that this technology is going to assist clinicians and be able to achieve significantly better clinical outcomes. I keep telling people it's going to be a dedicated physician along with, or dedicated clinician, along with an empowered patient and generative AI. And that triad is going to achieve outcomes 10 times better than any of those individual parts could do alone.
Yeah, that is fantastic. And the way I see it, rather, and you did mention that spread out fear sometimes about the idea of replacement clinicians. To me, it's more like enhancement, the way we practice medicine and make us more efficient. But on the flip side, I can tell you that as a coach for physicians, oftentimes are very reluctant to change. And that's the reality, right? So we went through all this long, exhausting training, and sometimes getting massive changes like the one these technologies could bring. Oftentimes I hear a lot of resistance. To me, the way I see it is just not a matter again about the if, but the when we are going to have all this technology available for our everyday practice. But having you on the podcast, I want to see if you have any reflection for those that still feel like I would say even in denial of this technology or even resistant to adapting for their practice.
I would go back to what I said a few minutes ago, that when there is resistance or resistance to change, almost always it's driven by fear. And I think that today the biggest concern, as you say, is will it get replaced? Will my income be compromised? I think there's a lot of financial fear that this tool could become so powerful that in the minds of people, we don't need clinicians. And so I think we need leadership. This is individual clinicians already. I know dozens, if not hundreds of individuals who are using generative AI to help them. Some of them are actually using it to help their patients. But I think that overall, this shift from fee-for-service to capitation, I think that's the big leap. And as you say, leadership is key. And I talk in the book about an A to G model, which is how do leaders help other people overcome their fears? And to do that, you've got to understand the fears. They have fears that they've heard many times, work smarter, not harder. In the end, they work harder. They don't believe you. They don't trust you. They think that you have some nefarious purpose, that you're going to get rid of them once this technology is available. They have fears that they're never going to see their family. They're never going to get home. This technology is going to actually slow them down. And this A to G model is one that can drive that process. The first thing it has to do is appeal to the heart. In the end, doctors are very dedicated. They're very hardworking. They went into medicine for all the right reasons. The healthcare system, in many cases, sucked it out of them. Don't get me wrong, but it's still there at some deeper level. And an aspirational vision is a combination of inspiration and reality. If it's just inspiration, it's a dream. If it's just reality, it's work. But if it's a combination, that's what I call an aspirational vision. And an aspirational vision is this opportunity to be able to improve the health of people, to be able to prolong good life, to be able to avoid heart attacks and strokes and kidney failure. And as the clinician side, to be able to deepen the relationship with patients and reduce the burnout. I think that aspiration has to be well specified as to what's the destination. You could say, what's the why that you used earlier in this podcast? If every doctor thinks that they're going to have to spend an hour with patients explaining generative AI, they're not going to be able to do it. They don't have hours in the day. The behavior isn't that you're going to have to teach patients how to use generative AI. It's that you're going to have to give them the link to a video or give them an article or send them to an educational class. There are a lot of different ways that can be done. And that's why I believe that we're going to have to work together. And this needs to be led, I think, at the national level by the societies that exist, as well as the agencies, the NIH and other educational places. They need to understand the context. We have the chance in this podcast to talk about the context of American medicine. They have to understand the 400,000 people dying from heart attack, dying from misdiagnoses, the hundreds of thousands more dying from preventable heart attacks, strokes, kidney failure, the 250,000 people dying from medical errors. Data. They need to understand the facts and the numbers. How does generative AI work? What are the outcomes that sit in place? How will it impact them? They need to have engagement, the leader of the leader. No one cares how much a leader knows, so they know how much a leader cares. And often we don't show that. We send emails and written correspondence or broad conferences. No, you got to sit down with people and have the conversation. The faculty is also supportive. You need people in IT who can train individuals in this technology. You need CFOs to be able to negotiate better contracts, ones that are based upon pay-per-value, payment capitation. It's got lots of names to it. And you need a governance structure with incentives like today, MIPS and MACRA that pay $1.50 more every time you recommend a mammogram. No, you need incentives that tie into the ability to keep people healthy and avoid these life-threatening problems to prolong healthy life. Yeah, these are the types of steps that clinicians have to do. And it's not that it's easy. It's just that's what leadership is about. I often say to young leaders who come to me and say, it's so hard to make change happen. I say, if you're not getting resistance, if you're not getting pushback, you're not leading. You're just being an administrator. Administrators make sure individuals get paid at the right time. They make sure the right forms get submitted to the government. Leaders make things happen that otherwise would not. And the beauty of that is that once that change happens, people would never go back to where they were before.
That is fantastic. But as any new technology, there's always pros and cons. And I'm going to give you an example, and I want to see if you can go more deeper on your insights around the cons of this new technology. I'm very passionate about Latina community as an Hispanic physician, and I work with telehealth companies that are improving access of care through telemedicine. And I work with a few of them and very I feel very grateful to have this opportunity to serve people that just don't have access to any physicians around the area where they live. But on the flip side, you see also the social determinants of health. Some of these people might not have access to the technology that would be able to allow them to even get connected for these appointments. And I have seen this beautiful opportunity to serve them into the trade-off of oftentimes not being able to serve them due to all this lack of access to even a smartphones or a camera and so on and so forth. As these technologies are advancing, more digital health, access of care will improve, but we have this trade-off of how we can serve minority. So I don't know if you can elaborate more in general, what do you see the cons of artificial intelligence? Or maybe you can get deeper into social disparity of health and how we take care of minority groups.
This is an area that I am very interested in. I write about it in my books. I just actually published a piece in Forbes about how generative AI will magnify and improve the health, particularly in people in socioeconomically challenged areas. So I'll offer you three thoughts. The first one is, remember, generative AI can speak Spanish as well as English. It's an immediate ability to go across languages, but I'm just using that as the example of the Latino community. Obviously, there's a lot of other communities. I think it speaks 40 different languages. And so it can provide information in a written form. It can do the ChatGPT 4.0 is verbal. You talk with it rather than typing into it. It can understand Spanish, it can respond in Spanish. So language becomes far less of a problem. The second thing about it is exactly what you're saying. People in socioeconomic communities, there's just not enough medical resources to serve them. And this is an opportunity where I think people who have today great disparities in care, this will shrink it. Why is that? Because they can get a lot of expertise. And I want to stress this. The traditional AI application provides information, but it's not usable. This provides information that is usable. So they don't have to start at the beginning with trying to find a primary care doctor who's almost impossible to find, waiting 3 or 4 months to get seen, and finally getting seen and then you referral to a specialist, to waiting 3 or 4 months to get there. You can have a much better knowledge about what exists. The question becomes now, how do you support them in terms of the access to care, the technology that's there? And the article that I wrote about encourages people to create community centers. You can create it in a church if the church is not being used during the day, or obviously on Sunday it's used, but the other days of the week. You can do it in a community center. You can do it in a lot of different places. And I've actually promoted the idea of saying, let's use healthcare workers for the community. Many of them are in social services right now. Maybe you could have 10 of these workers who can train people from the community at an affordable cost with one clinician there in case something pops up that's life-threatening. And you could take 10 of these different community centers in different communities and support it with one telehealth specialty center with 3, 4, 5 different specialists, the most common ones being available to support the clinician in these different areas. When I look at the aspects of the social determinants of health, every one of them is valid. The problem with them is they're so big. Housing, we're talking about hundreds of thousands of dollars for a house. Even for an apartment, it's probably cost $100,000 to create a facility for someone. And you have large numbers of people who are in that situation. We're talking about job creations in difficult communities. These things have to happen. They're just not going to happen very fast. And when I look at why there's this disparities in health, the social determinants of health exist, but I think that the way they're playing through right now is in terms of chronic disease. And I think that communities that have higher incidence of chronic disease, and you know they do. Why is that? Because the nutrition is not what it should be, because the stores near them don't have the produce or the vegetables at a reasonable price they can afford. They don't have a chance to exercise because the community might be dangerous or because they're working 2 jobs. Lots of different reasons why. But if I could at least intervene relative to chronic disease, if I can reduce the incidence of diabetes, which is very common in the Latino community, or hypertension that's very common in the Black community. So each community has its own set of chronic diseases that then translate into these medical problems that we discussed earlier. So that's the approach that I would take. Not that I would not support everything around the social determinants of health, but that's going to require the politicians and the businesses and the federal government, and you and I don't control that as clinicians. But we can focus on the areas of chronic disease. We can maximize prevention. Every Sunday, my wife says, okay, I need to plan the food for the next week. and she puts into ChatGPT the kinds of things that we're looking for relative to, are we looking to lose weight, maintain our weight, add muscle? Are we looking to, what kind of cost budget are we looking at? And it gives her a shopping list and recipes for every night. That can be done. Now, again, I'm very empathetic and sympathetic to people who are really struggling economically because they don't have the choices. But for most of the people, I'll say in the typical middle class, people working a job, doing construction, teachers, in some other way, firefighters, police officers, contributing to the community, they're in a place where they can afford to be able to make good choices. Not extreme choices, but good choices. And again, I think the technology can allow that to happen. And if we can reduce diabetes, take it back to where it was 20 years ago, minimize fast food and replace it, not with processed sugar and white flour, but with the kind of foods that people ate 20 years ago and maybe still eat in the places they might have come from. I think that we can do a better job than we're doing today. So there's a lot that can be done, but I don't want to wait till we build 10,000 more houses or until we create jobs that are going to be difficult to do, or all the other pieces that we know are the right things. Don't get me wrong. Get supermarkets to go back into the communities or get doctors to go there. I want those things to happen, but I'm also a realist. I want to do the things that I can do now so I start saving lives next year, not waiting for a decade from today.
Agree. Totally agree. And one of the things that I like about what you were mentioning was this concept of serve others, right? And that's the perfect segue into philanthropy. And I personally, like, the way I embrace coaching is like I've coached physicians that are going through hardship or burnout. They're entertaining a career transition or change. And the way I see it is any physician that I can help, it will actually have an expansive event and make things better in the healthcare in general, because we want to empower the physicians. Those are the ones that will lead the future of the healthcare system. And we've been talking a lot about leadership. Physicians that are burned out, moral injury, etc., are not the ones that will be in the best position and mindset of leading teams, etc. So now, when we talk about philanthropy, I want to share your thoughts. You already mentioned how to serve others, and I know you have donated the profits of your books to Doctors Without Borders. I want to hear from you. What are the drivers of why you have decided to do?
It's the person that I am, and I believe it's the person that most people who go into medicine is. That's why we did it. We went into medicine not to make a lot of money. We could have made a lot more money. We all had great grades. We could have made a lot more money in the finance world or the business world, but we wanted to help people. That's why we chose to be clinicians in the first place. It just got sucked out of us by medical school and residency and the challenges of the current healthcare system that's there. I started early on, traveling to other countries to fix kids with cleft lip and cleft palate. I've been to Mexico, I've been to Central America, South America multiple times. I recently, last December, went to the Philippines, operated on kids on a mission trip. It gives me tremendous joy. In fact, every clinician that I've seen doing that has come back just filled with enthusiasm, filled with gratitude. It's amazing because we tend to think we're just working too hard. And then you go to another country, you work 12 hours a day, you often have intestinal problems, you're not staying in the best circumstances, and you come back with this big smile that stays on your face for a long time until you get back into the current system. That is not people oriented. When I was the CEO, there was that tsunami in Sri Lanka. And it happened, I think, like the day before Christmas. A lot of people were on vacation. I sent out an email to the physicians and I said, there's been this tsunami. I'm happy to organize a trip to go there to provide relief work. But I got to warn you, I can't promise there'll be clean water. I can't promise there'll be edible food. And there's been a internal civil war going on now for 10 years. But if you want to go, just let me know. And I figured I gotta get 3 or 4 people because I was working with Doctors Without Borders at that time. I had over 200 people who volunteered to go. We sent 8 different missions there, and every single one of those people came back fulfilled. Now, I don't want listeners to think that I don't understand the reality of practicing medicine today. People with young kids and families and struggling to survive, it's a privilege to be able to take the time away, to be able to go to these countries, to be able to do some of that work. So I'm not offering that as, in quotes, the solution, but I am just saying, to the point that you're making, we shouldn't underestimate how important that is. And to people who are able to dedicate a night a week to go to a local community, a night a month to go to a local community to help people who otherwise couldn't get that care. The one thing I'll promise you is you're going to come back a lot happier, than you do in the current world, where every time you want to do something for a patient, you've got to call an insurance company and battle with an administrative group, or fill out a bunch of paperwork and claims forms and all the other pieces that are there, or try to meet some metric out by Medicare to get another small amount of dollars to make the practice. There's just something about doing things for other people that my observation is that it fills people with joy. And for me, it's done that. And I've prioritized that. In fact, when I joined Kaiser Permanente, my original plan at that time was actually to travel around South America, repairing kids with cleft lip and cleft palate who couldn't otherwise get care. And then a plastic surgeon in Kaiser Santa Clara crashed an airplane tragically. It was an engine failure. And they called me up to say, would you be willing to come here for a few months? My entire career would have been different had that plane crash not happened. And I never would have even known that Kaiser Permanente existed. That's the serendipity that we talked about early in the program.
So now, as we get close to the episode, it's been amazing, this conversation with you, Dr. Pearl, but how do you envision healthcare in United States in the next decade? How do you foresee the changes that will happen, and how we're going to be practicing medicine 10 years from now?
I see a fork in the road. Either we in medicine are going to drive the change, or someone outside medicine will do that. And I believe that we're going to be a lot better off if we drive the change, which is why I come on podcasts like your own, speak at conferences, wrote the book ChatGPT MD. I think that for us to make the change happen, we're going to have to form medical groups. It could be in primary care alone. ChenMed is a great organization that has done this, particularly in the Florida area, where they take on the sickest of patients. They see them once a month, believe it or not, but they're willing to take the risk of capitation and be able to deliver by providing better care to people and keeping them healthier. But I'm also a big believer, maybe because I came out of Kaiser Permanente, in multi-specialty medical groups, because medicine has become so complex that when the specialists come together and work as a team, I have to think about my mom. At the end of her life, she had a chronic leukemia that then flared into an acute leukemia. Her blood became thick. She had a stroke because of the blood clotting to the brain. She was in the hospital in the ICU before she went into hospice. And she had a hematologist, a cardiologist, a neurologist, etc. And every one of them came by every morning. They wrote a note in the chart, and they never talked to each other. There was no collaboration. There was no cooperation. Sometimes the medications they ordered conflicted with each other. Hospitalists are often the people who make all the pieces work well. And I really appreciate the work that you and your colleagues do in that area. But we really should have a single group of people talking about these things, figuring out the best way to go. So we're going to create those groups, be willing to take on the risk, be able to create a leadership structure. And I'm going to add a piece right now, and it may not be particularly pleasing to some individuals. We're going to have to be willing to move from individual autonomy to group autonomy. If we want to preserve the autonomy, we have to be able to say, we'll take the financial accountability as a group, and we will figure out the best way to provide care. No one's going to tell us. No insurer is going to tell us what to do. We will do it. But that's different than every individual deciding what he or she wants to do. It has to be best practices in maybe 80% of the thing. 20% of the time, we don't quite know what to do, and everyone has to try to figure it out. But when we know what to do, we have to all do it. And that's what's going to allow us to be successful in that model, or it's going to happen to us. And I've written about this in the past. Likely will come from one of the big retailers, maybe someone like Amazon, who will take it over and who will see clinicians as simply being the hireable, paid pieces of the equation, but not the leaders, not the drivers, not the values that we learn in medical school and in residency when it comes to how patients should and need to be taken care of. It's going to come from either inside or outside. Clay Christensen was a brilliant professor, wrote quite a number of books, The Innovator's Dilemma being one of them. He unfortunately died, but he was a good friend of mine. And he wrote these books about disruptive change, disruptive innovation, disruptive technology. And he pointed out that almost always, number one, they come from outside the industry. Why is that? Because people inside the industry are afraid to give up the things they have. And people from the outside are willing to do it. These are the entrepreneurs. And number two, it often begins by taking care of the people, I'll say, at the bottom of the socioeconomic scale. And maybe that's what will happen. As I say, I wrote that piece about Medicaid, but it's also possible in medicine that will happen at the top. Because even the people at the top of the economic scale are having increasing difficulty getting the care that they need. They can't get the appointments. They can't get the quality outcomes. They can't get the service. Telemedicine, you mentioned earlier, it's almost impossible to have a telemedicine visit these days. We're back to insisting that people come to the office. Fewer than 10% of the visits are telemedicine, even though during the pandemic, went as high as 60% without any quality problems that I've heard about as a consequence of that. Now, I think the most likely thing is it's going to happen outside, and it will happen to us. And my hope and my goal, and why I speak and why I write, is to encourage people inside medicine, for I believe that they will be the ones who can lead the process best and are most likely to come up with the answers that are going to be best for patients, but also best for the providers of the healthcare.
Fantastic. I love the message, and I'm very grateful to having you on this episode, Dr. Pearl. Until next time, thank you.
And if people want any more information, they can go to my website, which is robertpearlmd.com. And if they do read the book and they have thoughts and disagreements and ideas, please let me know about it. You can reach me through my website, and I look forward to learning from the audience. As I've learned as a teacher, you often learn a lot more from your students than you're able to teach them. And I look forward to together making American medicine the best in the world. Thank you for having me today, Miguel.
I love it. I love it. Until next episode. Bye-bye.